All right, can everyone hear me?
Sure can.
All right, sorry, I'm just kind of getting my stuff situated here on my screen. All right, so my name is Helen Melnick. I'm a nurse practitioner with the WVU and Hepatology Department. Today we'll be discussing cirrhosis, its causes, diagnosis, management, and complications, with a special focus on hepatitis C related liver disease. This presentation is designed to give a comprehensive overview, and we'll talk through both the pathophysiology and the practical management strategies. So here's our roadmap. We'll start with what cirrhosis actually is and then move into the mechanisms behind it. We'll review the major causes, including a dedicated section on hepatitis C. After that, we'll cover diagnosis, management, and the major complications clinicians need to anticipate. Finally, we'll wrap up with key takeaways and questions. So what is cirrhosis? Cirrhosis is the end result of chronic liver injury. Over time, normal liver tissue is replaced by fibrosis and regenerative nodules. This architectural distortion leads to impaired liver function and increased resistance to portal blood flow. Importantly, cirrhosis is often silent until late in the disease. So regardless of the underlying cause, the mechanism is similar. Chronic injury leads to hepatocyte death. Stellate cells become activated and deposit collagen, and then fibrous septa form and regenerative nodules develop. This disrupts the normal sinusoidal structure, causing portal hypertension and impaired metabolic function. So, what are the major causes of cirrhosis? The most common causes vary by region, but globally, viral hepatitis, especially hepatitis B and C, remain a major driver. In the United States, alcohol and MASH are leading causes, and then autoimmune hepatitis, cholestatic diseases like PBC and PSC, and genetic conditions such as hemochromatosis or Wilson's disease are also important contributors. Hepatitis C is an RNA virus transmitted primarily through blood exposure. About 75 to 85% of infected individuals develop chronic infection. This chronicity is what drives long-term inflammation and fibrosis. Before the advent of direct-acting antivirals, HCV was one of the most common reasons for liver transplantation. Direct-acting antivirals have revolutionized HCV treatment with cure rates above 95%. Treatment is typically 8 to 12 weeks and well tolerated. Even after cure, patients with advanced fibrosis require ongoing HCC surveillance, which we'll talk a little bit more further in the presentation. Fibrosis regression is possible, but cirrhosis may not fully would not fully reverse if they have progressive cirrhosis. So HCV causes persistent hepatic inflammation. Over years or decades, this leads to progressive fibrosis. Not everyone progresses at the same rate, so different factors including alcohol use, HIV co-infection, male sex, older age at time of infection accelerate fibrosis. Even after viral cure, again, they remain at high risk for hepatocellular carcinoma. And so I'm not going to go too far into Hep C specifically in this presentation because I'm going to be giving another presentation in October that I'm going to go into specifically Hep C with cirrhosis treatment. But I really want to give everyone a good basis of cirrhosis in general. So we're going to kind of dive back into that a little bit more. So, early cirrhosis is often asymptomatic. As liver function declines, patients may develop fatigue, anorexia, jaundice, pruritus, and abdominal distension. Physical signs like spider angiomas or palmar erythema reflect impaired estrogen metabolism, and many patients present only when complications arise. On exam, you may find hepatomegaly early on or a small shrunken liver in late disease. Splenomegaly suggests portal hypertension. Ascites, caput medusae, which is the appearance of a swollen, engorged veins radiating outward on from the belly button across the abdomen. And asterixis indicate decompensation. Asterixis in particular is a hallmark of hepatic encephalopathy. Diagnostic approach. Diagnosis involves a combination of labs, imaging, and sometimes biopsy. Labs may show thrombocytopenia, elevated INR, low albumin, or an AST-ALT ratio greater than 1. Ultrasound is the first line for structural assessment. Elastography helps quantify fibrosis, and biopsy is reserved for unclear cases. Non-invasive scores like FIB-4 and APRI, which is AST to platelet ratio index, are widely used because they're inexpensive and validated. Elastography provides a more direct assessment of liver stiffness, and these tools help stratify risk and guide management without requiring biopsy. So I wanted to dive in a little bit more into these tests and why we use them and when we use them, because this is the kind of thing that can be done in primary care or, pretty much any clinic where you have concerns of potential advanced liver disease. And then this can kind of guide to see, do they need to come and see us in hepatology, or do we need to have further follow-up or screening of these patients? So when we evaluate advanced fibrosis and specifically MASLD, we start with FIB-4 because it's the most validated first-line non-invasive test. It's recommended by the AASLD, AGA, and multiple international societies as the international screening tool in primary care and in endocrinology settings. In MASLD, a FIB-4 below 1.3 has a negative predictive score around 90 to 96% for excluding advanced fibrosis. A score above 2.67 has a positive predictive value of about 60 to 80%. Roughly a third of patients fall into the indeterminate range and need elastography or biopsy for further evaluation. Because age inflates the score, we raise the lower cutoff to 2.0 in adults over 65. And FIB-4 was originally developed in HCV and HIV co-infection, where the classic cutoffs were less than 1.45 to rule out severe fibrosis, um, and greater than 3.25 to rule it in, with over 90% specificity. Over 30% of patients fall between those thresholds, and then a Cochrane review confirmed that the low cutoff of 1.45 performs best for ruling out severe fibrosis in hepatitis C. So, and I'm kind of going into these just to show that the FIB-4, it is different cutoffs depending on the cause of the suspected fibrosis. So in hepatitis B, FIB-4 has been validated with slightly different cutoffs. It's less than 1 for rule out and greater than 2.65 for rule in, though the overall performance is moderate with that. So moving on beyond FIB-4, APRI performs poorly in MASLD with low sensitivity at higher cutoffs. So it's not super useful as a rule-in test. And I'll say in our clinic, we don't use that much. We kind of use FIB-4 and then move on from there. So the previously known as NAFLD fibrosis score, the NFS, behaves similarly to the FIB-4, but has a higher indeterminate rate. Its upper cutoff, however, is highly specific for ruling in advanced fibrosis. And then as far as imaging, we're talking about the VCTE or FibroScan or ultrasound elastography. The FibroScan provides the strongest diagnostic performance for imaging fibrosis. Values under 8 kPa effectively rule out advanced fibrosis, and values above 12 kPa strongly rule it in, though positive predictive value still depends on disease prevalence. So I wanted to talk a little bit about if we do progress to liver biopsy for these people who we're, kind of trying to figure out, do they have cirrhosis? It's not necessarily clear from our non-invasive test that we've done so far. Are we trying to figure out what could be causing this inflammation? It's not clear. So cirrhosis on a biopsy is defined by two major processes, fibrotic septa and regenerative nodules. The fibrotic septa bridge portal to portal and portal to central areas, eventually encircling hepatocyte islands and distorting the normal lobular architecture. These bands are best appreciated on a trichome or reticulin stains. The liver then remodels into regenerative nodules, clusters of hepatocytes surrounded by fibrosis and lacking a normal central vein. Nodules can be micronodular, as in alcohol, as we see in alcohol-associated disease, macronodular, as we see in chronic viral hepatitis, or mixed, as they often evolve over time. Another hallmark is a sinusoidal capillarization or loss of fenestrations in the sinusoidal endothelium, which impairs exchange between blood and hepatocytes. As fibrosis progresses, normal landmarks blur, and portal tracts and central veins become difficult to identify, and the degree of this loss correlates with portal hypertension. And so here's some examples of what the biopsies look like at the different stages. So going into management. Management of cirrhosis focuses on three pillars: treating the underlying cause, preventing complications, and monitoring for hepatocellular carcinoma. Lifestyle modifications, especially alcohol cessation, are critical. Vaccination against hepatitis A and B is recommended, and early referral to hepatology improves outcomes. So, as discussed, management of the complications that arise from cirrhosis is mainstay of management. Portal hypertension is a major driver of complications. Increased resistance to portal flow leads to varices, ascites, splenomegaly, and renal dysfunction. Identifying portal hypertension early allows for preventative strategies such as beta blockers and endoscopic screening. Variceal bleeding is life-threatening. In general, screening endoscopy is recommended for patients with cirrhosis, but if portal hypertension is known, whether we've seen varices on imaging, or if we've seen it on, other signs of portal hypertension, non-selective beta blockers can be started without completing an EGD. Non-selective beta blockers reduce the portal pressure. In acute bleeding, and an inpatient standpoint, can also use octreotide, antibiotics, and we can do endoscopic band ligation, which is the standard. Secondary prophylaxis combines the non-selective beta blockers and repeat banding. So this is just an image of what it looks like endoscopically. You can see the long strands of the engorged varices in the esophagus. And then in the second picture, you can see what it looks like for us endoscopically when we're going in and actually putting a band on the varice. So just to kind of give you an idea of what that looks like, what we're doing is, so endoscopic variceal ligation involves suctioning each varix into a ligator cap mounted on the endoscope tip until a readout is achieved, and then deploying an elastic band around the base of the captured tissue, causing thrombosis, necrosis, and sloughing. Banding is generally repeated every 2 to 4 weeks until varices are eradicated or too small to suction, typically requiring 2 to 4 sessions, depending on the severity. So if we get to a point, though, where we are not able to manage the varices or ascites with medical or endoscopic management, then we talk about a TIPS. So a TIPS is a transjugular intrahepatic portosystemic shunt. It is a minimally invasive interventional radiology procedure that creates a channel between the portal vein and hepatic vein. The goal is to decompress the portal vein by providing a low resistance bypass around the cirrhotic liver. The main indications are refractory ascites and recurrent variceal bleeding, despite optimal therapy. It's also used for hepatic hydrothorax and occasionally Budd-Chiari syndrome. TIPS is very effective at lowering portal pressure, which is why it can dramatically reduce ascites formation and prevent further bleeding. But because the blood bypasses the liver, the risk of hepatic encephalopathy increases, especially in older adults or those with baseline cognitive issues. Cardiac function is another key consideration. TIPS increases venous return, so patients with heart failure or pulmonary hypertension may not tolerate it. Over time, shunt stenosis can also occur, so Doppler ultrasound surveillance is important. But overall, TIPS is a powerful option when standard therapies fail, but it requires careful patient selection and close follow-up. This is just kind of an image of whenever the interventional radiologists are doing the procedure and kind of the idea there. So the goal with this is to reduce the portosystemic pressure gradient to less than 12 millimeters of mercury, which is the threshold below which variceal bleeding and ascites are unlikely to occur. And then they also try to make sure they create the smallest necessary caliber shunt. It's typically about 8 millimeters, to balance efficacy against the risk of hepatic encephalopathy and cardiac overload. Ascites. So ascites is the most common complication of cirrhosis. Management starts with sodium restriction and diuretics. We usually start with spironolactone 100 milligrams and furosemide 40 milligrams daily, with parallel dose escalation maintaining a 100 to 40 ratio. And then we typically go up to spironolactone of 400 and furosemide of 160. We don't like to go too much above that, but again, a lot of this is comes down to being patient specific and what they're able to tolerate. We also complete large volume paracentesis when ascites becomes tense. And then, as we talked before, patients who do not respond to the medical management may need tips. Um, and then anytime you have new onset ascites, we generally prefer perform a diagnostic paracentesis. The things that we look at that specifically are the SAG. A gradient of greater than 1.1 indicates portal hypertension with high accuracy. We also look at a PMN count. Greater than 250 cells support spontaneous bacterial peritonitis, which we know is a big concern. It needs to be treated immediately. We also look at the total protein. Lower levels are typical of cirrhosis, whereas higher levels suggest a cardiac cause. So this is really important because in the hepatology world, we talk about is the ascites our issue or not? Because you can also have it from a cardiac cause. And so that comes down to who really needs to be kind of driving the diuretic management depending on the cause. And then we usually do a culture as well. When we're talking about ascites, we talk about the different grades of it. So grade one, we talk about is mild and only detectable on imaging. Treatment usually doesn't improve outcomes. Grade two is what we consider moderate and is again managed with a sodium restriction and diuretics. Monitoring focuses on weight trends, electrolytes, and signs of overdiuresis. Once ascites improves, diuretics are reduced to the lowest effective dose. And then we usually keep a really close eye on electrolytes just because common diuretic related issues include gynecomastia, muscle cramps, electrolyte abnormalities, and renal dysfunction. Hepatic encephalopathy. So hepatic encephalopathy occurs when ammonia and other neurotoxins accumulate because the liver can't detoxify them. Symptoms range from subtle cognitive changes to coma. We grade HE using the West Haven criteria, and this is on the screen here. So we talk about that as like covert or overt hepatic encephalopathy. So grades 0 through 1 are covert, and there's no obvious clinical signs that but show up on psychometric testing. So if this would be something you would do a test of how many animals can they name in a 10-minute period, and if they aren't able to do that. Even mild hepatic encephalopathy affects driving, fall risks, and quality of life. So if you have confirmed hepatic encephalopathy, we have a conversation pretty early on with patients about that they should not be driving just because they're a risk to themselves and other people on the road. Now, overt hepatic encephalopathy, so grades 2 through 4, progresses from lethargy and disorientation with asterixis to somnolence and confusion, and finally to coma. So overt hepatic encephalopathy develops in about 1/3 of patients with cirrhosis and can be episodic, recurrent, or persistent. After an episode resolves, treatment focuses on preventing recurrence. So lactulose is first line, titrated to 2 to 3 soft bowel stools per day. We often talk about the Bristol stool scale on here because I also work in GI. They really need to be soft. Should not be straining. We should be completely avoiding constipation in these patients. Rifaximin is added for secondary prophylaxis, and the combination of rifaximin with lactulose is the standard of care for the recurrent hepatic encephalopathy. There's also some data out there as far as with zinc supplementation. It's considered when symptoms are persistent despite the standard care and if they have evidence of low zinc levels. And then we recommend avoiding sedatives whenever possible. The overall goal is to reduce ammonia production, prevent recurrence, and maintain cognitive function. Hepatocellular carcinoma. So cirrhosis is the strongest risk factor for HCC. Surveillance with ultrasound, CT, or MRI with an AFP or an alpha-fetoprotein every 6 months improves survival by detecting tumors at earlier stages. AFP levels can rise in the setting of hepatocyte injury, regeneration, and malignant transformation, making it a clinically important primary biomarker for hepatocellular carcinoma surveillance and monitoring. Treatment options depend on tumor size, number, and liver function, ranging from resection to transplant to systemic therapy. For patients with decompensated cirrhosis, transplantation is the only curative option. The MELD score predicts mortality and determines transplant priority. Post-transplant outcomes are excellent with more than 80% 5-year survival, but early referral to a transplant center is key. So let's talk a little bit about the MELD score as well. So if you've ever seen any of our notes on patients who are cirrhotics, we calculate MELD on everyone because it's a really useful tool for us. But I just wanted to kind of update because this has been over the last couple of years that we've gone to using the MELD 3.0. And so this is the current scoring system used for liver allocation in the US. And the major updates with this include that they have adjusted it for female sex. So women receive an additional 1.33 points to address prior waitlist mortality disparities. Albumin incorporation, this improves assessment of synthetic function and nutritional status. Interaction terms, we're looking closer at between bilirubin and sodium and albumin and creatinine, which improves the calibration. And then the creatinine cap was lowered from 4.0 to 3.0, reducing overestimation of kidney dysfunction, especially in patients with low muscle mass. Simulation modeling shows that the MELD 3.0 slightly reduces waitlist deaths compared with the previous MELD. So that's huge, especially we're saving lives just by using a better tool to keep an eye on this stuff. So the MELD score serves two main purposes. The first thing is the prognostication. So higher scores correlate with higher 90-day mortality. A MELD of 6 corresponds to roughly 2% mortality, while a MELD of 40 approaches 70%. Patients with MELD less than 12 have a very low short-term mortality risk, even with major surgery. And then the second thing is the organ allocation, which we were talking about. So the US liver allocation follows a sickest first model, prioritizing patients with the highest MELD scores. The acuity circles policy further broadened geographic sharing for higher acuity patients, but it's why making sure that these are as accurate as possible is really important for these people trying to get livers. So primary indications for liver transplant. So any acute decompensating events, including severe ascites, hepatic encephalopathy, variceal hemorrhage, regardless of MELD score. MELD score greater than 15 in the absence of decompensating events. And so we start referring people to transplant centers as soon as we start seeing a MELD of 15 as if it feels like it's appropriate. Hepatocellular carcinoma, most centers use the Milan criteria. So they look at this as like a single lesion that's less than 5 centimeters or less than 3 centimeter lesions. And if there's no extrahepatic disease, they talk about like their criteria for transplant. Acute liver failure is also an indication, and then acute on chronic liver failure. And other indications that require like MELD exceptions because their numbers are not going to be as reflective with these conditions are going to be hepatopulmonary syndrome, portopulmonary hypertension, PSC with recurrent cholangitis, familial amyloidosis, primary oxalaria, and other liver-based metabolic defects. To summarize, cirrhosis is the final common pathway to chronic liver injury. Hepatitis C remains a major cause, though treatment has dramatically improved outcomes. Early diagnosis, management of complications, and surveillance for HCC are essential. With appropriate care, many patients maintain a good quality of life. And this is our GI and hepatology team here at Ruby Memorial in Morgantown. And I have some resources here. There are primary guidelines and sources used in this presentation. The AASLD and CDC resources are excellent, and ILC is up to date all the time. But if you guys have any questions, I'll take those now.